Okay, hello. And welcome everybody to our spring update meeting. I'm Bruce Robinson, DOPPS Program Scientific Director. It's a beautiful spring morning here in Ann Arbor, Michigan, and we're only sorry that we're not able to join with you in person for this spring update meeting. But thank you so much for all of you around the world joining with us. Next slide, please. All right, and so we typically hold our spring update meeting at the ERA EDTA, which is indeed in 2 weeks from now. And again, look forward to when the chance to do this in person for as soon as we're able to do so. We do have a number of scientific abstracts that will be presented in oral format at the ERA EDTA in 2 weeks, as listed here. And after this meeting next week, we'll send more information about the DOPPS scientific activities at ERA EDTA. Next, please. And this is indeed a really exciting time for us. The DOPPS program is celebrating 25 years. Believe it or not, 1996 was the year of launch of the study. So we're just thrilled to still be going strong. Next slide, please. In particular, we want to give a warm thanks to all of you who made the DOPPS program possible over this quarter century. Country investigators, consortium sponsors, especially our site investigators, site coordinators, and study patients in particular. Next, please. Many thanks as well to our study sponsors. Current sponsors are listed here, and our work would really not be possible without your commitment to our independent research to help improve patient care. So many thanks and much gratitude to you. Next. All right, well, indeed, the DOPPS program now has expanded over time. We're currently in 20 countries, over 775 sites, 34,000 patients total. So there's a lot going on, and just imagine all the input from everybody to help keep things rolling. Next slide, please. From the very start, we've had essentially the same program goals that are rewritten here into the more current terminology, but really following the philosophy from the very start. Number one is to describe real-world practice variation, and we do this with stratified random national sampling, which, when it was introduced by Bob Wolf, Fritz Port, and colleagues, Phil Held, was really very novel, but it's a very powerful approach to describing what's going on out there in real practice, and efficient as well. We leverage existing clinical data generally speaking, rather than de novo data collection. Secondly, our goal is to help identify optimal practices, and we do this by limiting bias, inherent observational analyses, both by design and analytic techniques. We look at clinical outcomes, but also patient-reported outcomes. Actually, we, from the very start, we're collecting quality of life data, so really at the vanguard of that, and this is really critical to our work right now as well. And then thirdly, and really importantly, we aim to have always and still aim to serve as a resource for the community. We've had over 300 core publications in peer-reviewed journals, multiple national and international collaborations, and really we want to serve as partners in research with the community by data sharing, by serving as a platform for ancillary studies. Thirdly, really importantly, helping with career development, and indeed, actually, over the course of the 3 hours today, we'll highlight a number of these sorts of collaborations and partnering, and highlight additional opportunities as well. I still think there's much more that we can do. Next slide, please. All right. Well, speaking of today's agenda, we have a 3-hour program. We're figuring that 3 hours is the very max that folks can handle by a remote virtual meeting. But of course, it's a packed agenda. And we will be actually having sessions related to the DOPPS study in central dialysis, and then our PDOPPS study, and thirdly, our CKDOPPS study of advanced CKD. We'll start that before that with a presentation on COVID-related work that we're doing. And before, just get the next slide, please. Right. Oh, just before getting there, just a note. we would love to have to hear from you at least through the Q&A function. So please feel free and comfortable using that and send us questions as they arise. And we'll do our very best, of course, to answer them, either by responding to the Q&A or via audio as well. There will indeed be time for discussion at the end of each segment. We have about 10 to 15 minutes at the end of each segment for audio discussion in response to your Q&A. We also have time to discuss new research directions at the very end of the program. And so we do ask you, feel free to submit ideas at any point for new thoughts about new research that you may have. Okay, and the next slide. All right. Well, as a prelude to our first talk, I just want to note that we're actually really pleased about recent collaborations that we have developed with the International Society of Nephrology, and really on two fronts. The first is in support of their educational programs. We've become a partner with the ISN, hosting joint webinars, video abstracts, and appearance on the Global Kidney Care podcast, featured on the ISN Academy website. And I'll give a shout out to Roberto Faquafijo for leading this in his joint role with the DOPPS and with the ISN. We have some screenshots from those activities on the slide here. And then secondly, along with the ISN, we have jointly conducted a worldwide survey about the impact of COVID-19 on the care of dialysis patients. We have manuscripts under development related to in-center HD, PD, and lower middle income countries. And indeed, we're also going to issue a vaccination survey in the coming few weeks as well. Okay, so with that in mind, we'll move on to the first scientific talk. And next slide, or actually, I'm sorry. What I'd like to do actually then is introduce Ryan Alward, who is a clinical and population health sciences PhD student, as well as a physician in training. And he's actually getting his PhD at the combination of the University of Bristol in the UK and the University of Cape Town, working in the UK closely with Fergus Caskey and colleagues. With that in mind, we'll move on to the first talk. So the talks will be given today. They were actually pre-recorded, but speakers are here concurrent with those talks to answer your questions through the Q&A function. All right, thank you, Ryan.
Hello everyone. Today I would like to share results with you of the impact of the COVID-19 pandemic on in-center hemodialysis services across the world survey. This was a collaboration between the Dialysis Outcomes Practice Pattern Study and the International Society of Nephrology. As a background to the burden of COVID-19 infection amongst people on kidney replacement therapy, these data show the proportion of the KRT census for DOPPS countries infected with COVID-19. We can see that patients receiving in-center hemodialysis, depicted in the pink bars, have been particularly affected compared to those in home dialysis, green, and those with the transplant in green, with wide variation across countries. Patients receiving in-center hemodialysis are at increased risk of exposure because of frequent traveling to and from the center and close contact with others in the center. Naturally, the more cases there are, the more deaths of people on HD as well. The second wave of the pandemic, depicted by the blue triangles compared to the first wave, pink circles, saw an increase in both number of positive cases and deaths as well. There was also wide variability in fatality across the DOPPS countries. Thailand reported no fatalities, whereas 34% of Italian dialysis patients died. Units have had to adapt policies and practices to continue dialysis services safely. These relate to how dialysis is conducted, as well as infection prevention and control, and testing policies. The aim of this survey was to assess the impacts of the pandemic on policies and practices adopted by centers worldwide, as well as the availability of SARS-CoV-2 testing and personal protective equipment. DOPPS surveyed centers in Gulf Cooperation Council, the United States, China, France, Germany, Italy, Spain, and Sweden early in the pandemic. The ISN was asked to collaborate on this initiative and leverage its extensive network of member societies and registries in order to include the global landscape of the impact of the pandemic on services. The survey was adapted after input from ISN members from lower and high income countries and deployed in late 2020, early 2021. The ISN asked countries to share a list of units in that country. We then randomly selected units from that list depending on how many total units there are in that country, similar to DOPPS sampling methodology. We then invited those units to participate by email. In the third stage, we used social media and mailing lists to invite all those who wished to complete the survey. These results were combined and presented by region. We did not receive any responses from China in stage 2, so we included responses from the April-May 2020 DOPPS survey, since China is one of the world's largest dialysis populations and SARS-CoV-2 was first reported there. Out of 113 countries with contact information held by the ISN, we received a list of units from 47 countries that were subsequently invited to complete the survey. There were an additional 31 countries represented in the open eBlast invitation, bringing the total number of countries to 78, as is shown in the first column by region. There were 412 total survey responses received, with the most being from Africa. The characteristics of the units by ISN region who responded are shown here. There were relatively few responses from low-income countries, those being from the Middle East and Africa only. About half of the responses received were from units in the public healthcare sector. Responses from Northeast Asia, which only include Chinese and South Korean units, were mostly academic tertiary dialysis services. Not surprisingly, most responding units were located in urban areas, except for North America and the Caribbean, which also features many units from rural and suburban areas. The combined number of cases that were confirmed by testing and those suspected by case definition, where testing was not available or not performed, are shown in this figure. Each color represents a category of the proportion of HD patients who were confirmed or suspected to be infected with COVID-19. Most units reported that between 10 and 20% of their dialysis census was infected, shown in green, whereas Northeast Asia reported no cases, in blue, in 91% of units. Not shown here, the proportion of deaths due to COVID-19 were overall less than 10%. We asked units to report whether diagnostic testing, for example PCR, was available early in the pandemic, around April-May 2020, at the time of survey completion, between November and February 2021, for all countries except China. Testing was only widely available in about a third of units early in the pandemic, and only rised to 2/3 at the time of survey completion. Africa and Latin America reported relatively lower availability of PCR testing. Not shown in this table, antibody testing was only widely available in a third of units at the time of survey. Respondents were asked to report whether various PPE items were not generally available, or if there was no moderate or severe shortages of PPE at any time of the pandemic. No shortage was reported by most units for plastic aprons, isolation gowns, eye protection, gloves, and surgical masks. There was a severe shortage of N95 type masks reported in 14% of units, a moderate shortage in 38%, and no shortage in 39% of units, with Africa being particularly affected. One of the social distancing recommendations by the Center for Disease Prevention and Control and other organizations is to increase the distance between machines to at least 2 meters. Only about a third of units reported that they were able to increase the distance between machines. A quarter of units were able to achieve the recommended 2 meters, and most others achieved at least 1 to 2 meters. Another recommendation is to decrease the number of dialysis patients in a shift to limit the risk of exposure. This is achieved by limiting the number or the length of sessions of dialysis. Most units reported not decreasing session length or the number of sessions per week, and most reported no or minimal missed sessions. 3/4 of units adopted a policy of cohorting positive cases to a specific shift. The survey also included questions about the impact of the pandemic on dialysis workers. At the bottom of the slide, we can see there was wide variability in the combined number of confirmed and suspected cases among staff. Many regions reported that more than 50% of their workforce was infected, in purple, whereas North American and the Caribbean and many Asian nations reported mostly no staff cases. Staff were rarely redeployed to other clinical areas, and 43% reported no shortage of staff was experienced. Disappointingly, only half of units reported that there was psychological support services available to staff. In conclusion, we were able to obtain responses from many countries of the world. There were challenges in testing and PPE availability globally, but varied between regions, reflecting the differences in burden and highlighting inequalities in resource provision. It will be interesting to see what effect access to vaccines and vaccination policies will have across regions. We are therefore working on a lower income country experiences manuscript and also an access to vaccines survey. Watch this space. We are very grateful to respondents, leads, and ISN and ARBOR research teams who contributed to this initiative. Thank you very much for listening.
Great. Ryan, thank you for that wonderful talk. And by the way, thank you for your leadership with respect to this project, which you've just been phenomenal at pushing forward in a very timely fashion. So thank you very much.
Thanks, Chris.
Yeah, you're very welcome. It's really interesting, I think, as you highlighted, that mortality on dialysis does appear to be very, very high, probably in the range of 10 to 20%. In terms of case fatality, really worldwide. And the real issue, I think, is community exposure. In some countries, community exposure really has been, particularly in some Asian countries, relatively low over time, and I think ultimately really helps protect our patients. Of course, a lot of concern in the recent 1 to 2 months with respect to burden in some of the lower to middle income countries, including South Asian countries, but South America as well. And I do think it'll be very interesting as our survey, with our, as you noted, the focus on lower middle income countries and access to therapeutics and PPE, et cetera, and of course ultimately vaccines. And we're starting to see more of a situation of countries that have versus have not as we move into this next phase of the pandemic. I was just wondering, Roberto, did any comments from your perspective, here in the States, but also seeing very closely what's going on in Brazil, particularly in recent months? Your thoughts as to where the pandemic may take us?
Yeah, I guess one thing that calls my attention from this experience, Bruce, is how the situation in the dialysis units mirrors what's going on in different waves of the pandemic. And one thing that I'm really curious to see is how the information acquired with the experience would impact future measures in dialysis units across the globe. I hope that our initiative together with the ISN might help really creating a source of experience description that might be helpful.
That's a good point as well. I mean, I think you're Ryan. I mean, we've actually seen fairly strong uptake of infection prevention and control measures in many countries. Somewhat decreased access to those measures in others. Ryan, has that been your take on this so far as well, based on the data?
Yeah, I think so. Obviously it depends on local resources, but I think that's been the challenge is the provision rather than people wanting to.
Right. Indeed. Yeah, my sense is, and the research will show this in coming months, but my sense is, at least anecdotally, that infection prevention and control, when the simple measures are applied in the dialysis unit, we're actually probably doing pretty well, actually, with respect to COVID prevention and control. It really, once again, is a question of community burden, but it may well be that the institution of those fairly straightforward measures do make a really important difference. And I do agree, Roberto, that moving forward, we may see some real changes to that approach overall, not only with respect to COVID, of course, but influenza, et cetera, et cetera. Yeah. So, okay. So thank you very much. We're just a minute past the time to pivot to our next session. So we'll do so. Ryan, thank you once again for all that you've done with this project, and thank you to the ISN for the opportunity for DOPPS to collaborate with you. Well, at this moment, I have the distinction